When a doctor recommends a treatment, how do we really know it works? For decades, the answer's been pretty simple. We trust the gold standard of evidence. But what if that standard isn't always so golden? What if, sometimes, it actually points us in the wrong direction? Today, we're going to dive into the really complex world of medical evidence and try to figure out what it actually takes to know what works.
Okay, so here's our game plan. First up, we're going to look at this so-called gold standard. Then, we're going to start to see the cracks in its foundation. After that, we'll meet some of the unsung heroes of health data, see them in action with a really cool case study, and then we'll wrap it all up with a new way of thinking called actionable data.
All right, first things first. Let's talk about this gold standard. We need to understand why this one particular type of study has been king for so long.
This is the big question, right? If you've got a new drug, a new therapy, whatever it is, how do you really prove, that it's better than what we're already doing, or maybe better than doing nothing at all? Well, for a very long time, the answer has been one specific kind of study.
It's called the Randomized Controlled Trial, or RCT. And the secret sauce really is right there in the name, randomization. By randomly putting people into different groups, you're essentially shuffling the deck. It makes sure all the different factors, like age, health status, even things you don't know about, get spread out evenly. This is huge because it gets rid of a ton of bias and lets you zero in on the one thing you're actually testing.
And that's where the magic really happens, in the comparison. You've got one group, the intervention group, getting the new thing. And the other group, the control group, gets a fake, like a placebo, or just the old standard treatment. Then you just compare the results. If there's a difference, you can be pretty darn sure it's because of the new treatment. It's a clean, elegant, and really powerful design.
Okay, section 2. And here comes the plot twist. Because as powerful as RCTs are, well, they're not perfect. Far from it. Let's start digging into some of the cracks in this gold standard. And there are a lot of them. For starters, these things can be incredibly slow and super expensive, taking years and millions of dollars. They're basically impossible for rare diseases. You just can't find enough people to enroll. And they often don't last long enough to catch some of the really rare but very serious side effects. Plus, in an emergency, like a pandemic, you just don't have time to set one up. But maybe the single biggest problem is this thing called external validity. This quote from one of the sources just hits the nail on the head. See, an RCT can be perfectly true inside the experiment. That's what internal validity means. The results are solid for the people in that study. But that's a totally different question from whether those results will actually work out in the messy, complicated real world.
So what exactly is external validity? Well, it's pretty simple. It's asking the question, hey, this thing that worked in a super controlled setting with a very specific, often healthier group of people, is it actually going to work for my grandpa or my neighbor or the diverse patient population that doctors see every day? And a lot of the time, the answer is maybe not. And that's a huge deal.
So, if RCTs aren't the whole story, what else do we have? Well, that brings us to section 3, where we're going to meet the other forms of evidence. These are kind of the unsung heroes of health data.
Okay, let me give you a really powerful, real-world example of this. Back in the 1980s, sudden infant death syndrome, or SIDS, was this absolutely tragic and terrifying mystery. The rates were shockingly high, and parents were, understandably, desperate for answers. But think about it. You could never do an RCT for this. It would be completely unethical to randomly tell parents to put their babies to sleep in potentially dangerous ways.
So researchers had to get clever. They reached into their toolbox and pulled out a different tool, something called a case control study. They looked back in time. They identified infants who had tragically died from SIDS, those are the cases, and they compared them to a group of similar but healthy infants, the controls, to see if they could spot any differences. And what they found was a massive breakthrough. There was a huge link. They discovered that infants who were put to sleep on their stomachs were at a much, much higher risk of SIDS. Now remember, this discovery didn't come from a gold standard RCT, but it was an undeniably clear and powerful signal in the data.
And here's the crucial part. Health officials didn't wait around for some perfect study that was never going to happen. They acted. They launched the Back to Sleep campaign, urging parents to put babies to sleep on their backs. And the result? It was incredible. SIDS deaths plummeted across the globe. The success of the campaign itself became its own powerful proof.
So this really shows us that it's not about having one magic tool. It's about having a whole toolbox. You've got things like cohort studies, which follow people forward in time, and the case control studies we just talked about. Each one has its own strengths and, yeah, its own weaknesses. The real key is knowing which tool is the right one for the job you're trying to do. All right, on to our next section. This time, we're going to look at a case where real-world data had to come in and basically correct the gold standard after the fact.
So picture this. It's 2014, and the CDC's advisory committee says that, for kids, the nasal spray flu vaccine is the way to go. And why? Well, because multiple RCTs, our gold standard, showed it worked better than the regular shot for children. On paper, it seemed like a total no-brainer. But then, something really weird started happening. As data started rolling in from the real world, from regular doctors' offices and clinics, it was telling a completely different story. The spray just wasn't working well. In fact, by 2016, its effectiveness had dropped to pretty much zero. And bam, the CDC had to completely flip its recommendation and say, don't use it. So what went wrong? Well, it all comes back to that idea of external validity. For whatever reason, maybe the flu virus had changed, maybe the vaccine manufacturing had shifted slightly, those clean, perfect results from the trials just didn't hold up in the real world. This is a perfect lesson in why you can't just stop looking after a study is published. You need to keep monitoring things as they actually play out.
Okay, so this all brings us to our final and maybe most important section. How do we make good decisions knowing that no single type of study is perfect? It's about embracing this idea of actionable data. I just love this quote. It calls all the areas of medicine where we don't have perfect RCT data the dark matter of clinical medicine. We know it's there, we know it's huge, but it leaves these massive information gaps. And doctors and patients are in that dark matter every single day, having to make calls without a perfect roadmap. We can't just pretend it doesn't exist.
So the goal can't be to find that one single perfect study. The goal is to gather actionable data. And what that means is finding evidence that's good enough to make a decision, good enough to act on. And you get it by looking at the whole picture, by pulling together all the sources you have available openly and objectively.
So what's the bottom line here? What should you take away from all of this? First off, no study is perfect. Period. Every single design has flaws. Second, it's all about using the right tool for the job. Third, we have to be smart consumers of information and critically look at the good and the bad of all data. And this last one is so important. Sometimes waiting for perfect data is just another way of deciding to do nothing, and doing nothing is still a choice.
And that leaves us with one last big question to chew on. In medicine and public health, where the stakes can be life and death, we always have to balance the risk of acting on imperfect data against the very real risk of not acting at all. So you have to ask yourself, when lives are on the line, is the hunt for perfect data sometimes the biggest risk of all? That's something worth thinking about.